can be small bowel obstruction or it can be a large bowel obstruction. Most common cause of small bowel obstruction, is development of adhesions, and most common cause of large bowel obstruction is malignancy. Okay, so first we are going to discuss small bowel obstruction. Small bowel obstruction. To begin with, I'll give you a basic idea of a small bowel obstruction. Generally, the small bowel obstruction occurs due to various causes. Most common cause is adhesions. Other causes can be malignancy, hernia, Crohn's disease, etc. Now, there is a patient with small bowel obstruction which is presenting with abdominal distension, bilious vomiting, inability to pass flatus and feces. We generally manage the patient with initially with conservative management with IV fluids. Once the patient stabilizes, then we send the patient for investigation. We generally get the X-ray abdomen erect supine done, in which we see that there is dilated small bowel loops or multiple air fluid level, and then if the patient is not resolving with conservative management, or if there is presence of sepsis or signs of strangulation, then we'll have to go for surgery. In surgery, the type of surgery depends on the reason of obstruction. If there is adhesions, we'll have to do adhesiolysis. If there is malignancy, then we'll have to do a small bowel reduction anastomosis. And now we are going to discuss this small bowel obstruction in detail. Okay, so what all are the causes or etiology? Most common is adhesions. Second most common is malignancy. You can remember it with the mnemonic MSC, malignancy, then hernia, and then Crohn's disease. Okay, this adhesions is important, and this is very frequently asked question. Maximum risk is associated with pelvic surgeries, followed by lower abdominal surgeries, followed by upper abdominal surgeries. Okay, so various options are given to you, like there is small bowel resection anastomosis, gastrectomy, low anterior resection, or you can say ileal pouch anal anastomosis or APR. So in pelvic surgeries like in APR, LAR, or with this ileal pouch anal anastomosis, this small bowel obstruction is very common as compared to with the small intestinal resection anastomosis or with a gastric resection. Okay, so this they will give in the options as APR, LAR, or ileal pouch anal anastomosis. So as compared to the upper abdominal or lower abdominal surgeries, this pelvic surgeries is having more risk of intestinal obstruction. Okay, this is important. Now, among the malignancy, the small bowel obstruction is generally seen in metastasis to small bowel or due to peritoneal carcinomatosis. It is very rare due to primary malignancy of the small bowel. Generally, it is metastasis to the small bowel or presence of a peritoneal carcinomatosis. Okay, this is important. Now, what all are the clinical features? In clinical features, the most common symptom or the first symptom is presence of colicky abdominal pain. Other symptoms can be bilious vomiting, abdominal distension, inability to pass flatus and feces, also known as obstipation, or complete constipation, or absolute constipation. Okay. Now, whenever the obstruction is in the proximal small bowel, there will be more vomiting and less abdominal distension. And whenever the obstruction will be in the distal small bowel, there will be more abdominal distension and less vomiting. Okay, so this is important. Proximal small bowel obstruction, distal small bowel obstruction. In proximal small bowel obstruction, there will be more vomiting and less abdominal distension. Whereas in distal small bowel obstruction, there will be less vomiting and more abdominal distension as compared to the proximal intestinal obstruction. Okay. Now, what happens is there is a fluid which is secreted into the small intestine. Now, you see, like this is obstruction here. There is a proximal bowel dilatation here, and there is a lot of fluid inside the proximal bowel which is dilated proximal to the site of obstruction. Now, person is swallowing air also, so there will be air fluid level which is present here, and due to this secretion or there is a fluid inside the small bowel, there will be a third space loss. Okay, so the patient generally presents with a third space loss or a hypovolemia. There may be presence of a hypovolemic shock, and in this air fluid level, majority of this air is swallowed air. And this question was once asked that it mainly contains of, or the major component is the major component here is nitrogen, N2. Okay. Now, initially there is a hyperactive bowel sounds. Okay, but if there is chronic obstruction or obstruction due to a prolonged period of time, there may be sluggish bowel sounds or absent bowel sounds. Okay, sluggish bowel sounds or absent bowel sounds in last stages of intestinal obstruction. Now, in last stages of intestinal obstruction, there is a sluggish bowel sound or absent bowel sound. Now, we have diagnosed the patient as intestinal obstruction, and now we are going to manage this patient. In management, initially we are going to give IV fluids. We are going to place 2 large bore IV cannulas, and we are going to give IV fluids, okay, to this patient. What is the fluid of choice? It's ringer lactate. Okay, now the fluid of choice is ringer lactate. Along with that, we will place Ryle's tube for nasogastric decompression, and we are going to put Foley's for urine output monitoring. we know that the patient is in third space loss, and we want to see whether there is adequate tissue perfusion or not. And the best clinical indicator for adequate tissue perfusion is urine output. Okay, so urine output is best clinical indicator for tissue perfusion. For children's and for adults, in cases of children's, the urine output should be 0.5 to 1 ml per minute, and in case of adults, it should be 1 ml per minute. So if there is a 60 kg male patient, and in case if the urine output is 60 ml in an hour, then we can send this patient for investigations. Now we have got the investigations done. The investigation of choice is X-ray abdomen, we generally send the patient for X-ray abdomen erect supine. If the patient is very sick, then this erect X-ray is difficult to obtain. Among these two, this supine X-ray is better. Then erect. Supine X-ray tells us the where is obstruction, what is the bowel diameter, whether there is gas in rectum which is present or not. Okay. Erect X-ray shows us the air fluid levels. If there is more than 3, normally we can see up to 3 to 5 air fluid levels. If there are more air fluid levels or multiple air fluid levels, then the diagnosis is intestinal obstruction. Overall, if you will see that supine is better as compared to the erect one. Okay. Now, if we are suspecting strangulation, if there is tachycardia, severe tenderness, fever, then we are suspecting strangulation, and then we should send the patient for CECT abdomen. Okay. Now, this is one supine X-ray and this is one erect X-ray. You can see here multiple air fluid levels. Okay, and here you can see a dilated bowel loop. Okay, now this CECT abdomen is done in high grade obstruction. High grade obstruction means if there is no bowel sound or absent bowel sound or sluggish bowel sounds, or in cases of some extraluminal cause is suspected, or if there is strangulation. And investigation of choice for low grade intermittent small bowel obstruction is enteroclysis. Okay. We can give CT enteroclysis also or only enteroclysis also. So the investigation of choice for low grade intermittent small bowel obstruction is enteroclysis. With X-ray abdomen, we can also assess whether the obstruction is of the large bowel or of the small bowel. Okay. So you can see here in this image, if the obstruction or if the bowel loops are peripherally placed showing haustration, peripherally placed bowel loops having wide caliber showing haustration, then it is large bowel obstruction. And whereas if the bowel loops are centrally placed, okay, then they are small bowel obstruction. And if it is a jejunal loop, generally there is presence of valvulae conniventis, in jejunum. This valvulae conniventis is a circumferential ring-like pattern. It is generally placed on the upper side of the abdomen, and you can see here there is a bowel loop like this, and there are multiple transverse small bowel valvulae conniventis which are circumferential ring-like pattern in the bowel. This is mainly jejunal loop which is dilated, and it is a small bowel obstruction. In ileum, there is generally no specific finding which is seen. There is a bowel loop which is dilated. There is no haustrations and no valvular conniventis. Okay, so ileum is placed centrally and is featureless. We can say that it is characterless. A characterless loop of Wangenstein is the name given to ileum. Okay. Now, we have diagnosed that it is obstruction and it is not responding to the medical management. Then we should go for surgical management. Management depends on the main reason for causing intestinal obstruction. If it is because of adhesions, then we'll have to do adhesiolysis. If it is because of malignancy, then we'll do resection anastomosis. If the obstruction is because of hernia, then we'll have to do hernia repair. If it is because of Crohn's disease, then again we'll have to do resection anastomosis. Now another point is how we can differentiate between a simple obstruction versus a strangulation. Okay, so in simple obstruction, versus a strangulation, you can see here that this is a bowel loop and there is a mechanical obstruction here. So this is a simple obstruction, but in case if there is twisting and if there is a mesenteric ischemia or there is a bowel ischemia, then it will lead to a strangulation. Okay, so this is a mechanical obstruction. But there is a preserved blood supply to the bowel. Okay, patient presents with colicky pain here, and the diagnosis is generally made with X-ray abdomen. This we have read. Okay, but in strangulation, generally there is a closed loop obstruction, and the blood supply is compromised. Okay, patient presents with abdominal pain. Along with that, there is presence of fever, tachycardia, leukocytosis, and tenderness. Okay, these are the signs of strangulation. In case if there is presence of fever, tachycardia in a patient with intestinal obstruction, then rather than going for X-ray abdomen, we should straight away go for a CT scan. We may find ischemia or pneumatosis or gangrene in the small intestine, and then we should go for urgent surgery. Okay. Now, the next topic is paralytic ileus. I generally, during my residency days, I used to receive a call, almost once a call every week, from the neurology ward, that there is a patient in their ward who is having abdominal distension and X-ray showing air fluid levels. So there is possibility of obstruction. You just come and see whether the patient is having obstruction or not, and in case there is any surgical intervention which is required or not. Whenever I go and I'll see the patient, majority of the patients were bedridden. They were taking some neurological medicines or some antipsychotics. There was abdominal distension with history of vomiting and inability to pass flatus feces. But the X-ray, in X-ray there was gas present in the rectum, and the electrolytes, whenever I ask them to get the electrolytes done, generally there is presence of hypokalemia. Okay, so on correction of the electrolytes and keeping the patient on nasogastric tube and nir per oral for 2 to 3 days, generally majority of the patients improve, and the diagnosis in these cases is paralytic ileus. Okay, it is not a small bowel obstruction. Okay, now I'll discuss paralytic ileus detail. Now there is impaired intestinal motility because of some neuromuscular failure. Okay, so the peristaltic wave is not going due to some neuromuscular failure. Okay, as the name suggests, paralytic. So there is some paralysis. Okay, now patient presents with abdominal distension and there on clinical examination there is absent bowel sounds. Okay, now what all are the causes or etiology for paralytic ileus? Any abdominal surgery, uremia, intra-abdominal sepsis, retroperitoneal hematoma, mesenteric ischemia, dyselectrolytemia, and drugs, opiates or antipsychotics. Okay, so these are the causes for paralytic ileus. Okay, so this abdominal surgery or this post-operative ileus is very common. Abdominal surgery, after abdominal surgery, also known as post-operative ileus. Generally, a few questions are asked regarding post-operative ileus. Which organ is responsible for post-operative ileus? Whether it is stomach, small intestine, or colon. So, organ responsible for post-operative ileus is colon. Okay, why? Because small intestine is earliest to recover. Okay, the peristalsis to recover, which is in 24 hours. Okay, then stomach recovers in 48 hours. Colon generally takes 3 to 5 days. So after any abdominal surgery, if there is abdominal distension or there are features of paralytic ileus, generally it is because of this colonic paralysis. Okay. Now, in this dyselectrolytemia, generally there is presence of a hypokalemia. We generally ask, or we generally correct the potassium. And in case if we are correcting potassium and potassium is not getting corrected, then there may be a possibility of hypomagnesemia also. So we should also get a magnesium done in case if even after giving potassium we are unable to correct potassium, then we should get a magnesium done. We should first correct the magnesium and then we will be able to correct the potassium also. Okay, and drugs are opiates and antipsychotics. Now, so clinical features I have already told you. The patient presents with abdominal distension. Obviously, due to distension, there is abdominal discomfort. Then there may be vomiting or nausea. There is presence of absent bowel sounds. And there is inability to pass flatus and feces. Almost all the features are of intestinal obstruction, but one feature which is not there, which is the characteristic distinguishing feature from intestinal obstruction, is the colicky pain. Colicky abdominal pain is absent. So this is very important to remember that the colicky abdominal pain is absent in paralytic ileus. Okay. Now we are getting the investigation done. For diagnosis, the investigation of choice here is X-ray abdomen. X-ray abdomen features are dilated bowel loops, presence of air fluid level, but there is presence of gas in rectum. Okay, presence of gas in rectum, which is a distinguishing factor. It distinguishes it from intestinal obstruction. So these 2 points are very important and they are asked in MCQ, that there is absence of gas in rectum in paralytic ileus. No, the gas is present in rectum. Okay, in case if the gas is present in rectum, we should wait. We should go for conservative management. Okay, and the management in this case is nasogastric tube placement, nasogastric tube in the tube, then restriction of oral intake, until bowel sounds return, and electrolyte correction or treatment of the underlying cause. Okay, so that is about paralytic ileus.